All right, thanks again, Seema. Good morning, everybody. Can I have my slides? Oh, that's my photograph of yesterday. So they had an ancient photograph where I was younger and better. All right, so even better. So I'm not a rare disease entity, it looks like. Oh my God. No, I don't want to. I don't want to get to the other half. So everybody is being born again today. It looks like, if that's the case. So tomorrow maybe you should move the podium a little bit to the other side. So that's my suggestion. Okay, my clock will start ticking. Right. So what we'll do in the next 10 minutes, 15 minutes is to understand the relevance of real world data. Something that you've been hearing again and again this morning is that we don't have data. Right. So somebody talked about morcellation, somebody spoke about whether chemotherapy should be given or not. Dr. Gupta very nicely told you about studies where they were not able to really conclude what they set out with. So that's where real world data can really fit in. So let's quickly understand the fallacies behind what we today think as high level evidence. No, that's the evidence pyramid for you. Randomized controlled trials somewhere come at the top. But remember that randomized controlled trial itself is a paradox. You're trying to recruit a set of patients who are very homogeneous and then applying that result in a very heterogeneous set of patients that you see in the clinic, right? So it's the best way to assess if an intervention works or not, but arguably the worst to say who will benefit from that intervention, right? There's a patient sitting across, you're talking about high PEC, and then that patient wants to know, am I going to get benefit out of this high PEC? What will you say? I don't know. And this is after tons and tons of randomized evidence have been generated, positive or negative. I'm not looking at you because you're a surgeon, Dr. Amita. I'm just generally looking at you. It's got nothing to do with high PEC, right? But in spite of this paradox, remember that that's somewhere at the top of that evidence pyramid. So when you talk about randomized trials, what you routinely see in a clinic may not typically fall into that group. For example, if you generally look at the demographics of a patient of a trial in advanced ovarian cancer, you will see that 50% of patients actually have performance status 0. Now just think for a moment, how many of you have seen a patient with ovarian cancer with performance status 0? Yesterday, I think Akshay was talking about advanced pancreatic cancer in another meeting. Locally advanced pancreatic cancer, performance status 0 is 60%. Have you ever seen a patient with pancreatic cancer who is asymptomatic and fully ambulatory? You're not running a screening program for pancreatic cancer, remember, right? So those are the kind of patients who go into many of these trials. And that is why sometimes when you try to put this into practice, this is what happens, right? You think all the women are laughing. That means all of you have done this. You've gotten something from Amazon and returned it back the moment it landed at your doorstep, which is what happens very commonly at my home. So I know what happens, as many fellows are coming to deliver, that many fellows are coming to take it back. And remember, giving it back is very difficult, right? There's a great big procedure behind that because sometimes my wife tells me, you better do it. So that's why. So when you don't get the answers that you're looking for, as far as your patient is concerned, what do? You morcellate the data, right? You're doing data torture, and then you will see that your confidence intervals are wide. So you want to say, what happened to that patient who was performance status 2? What happened to that patient who was 85 and above? Now, if you look at a run-of-the-mill randomized controlled trial, you'll find that about 5%, 10% of patients would be in that group that you're trying to ask that question. And Dr. Gupta very beautifully told you why that result is not reliable. And then what will you do? This subset analysis is hypothesis generating. We will do a bigger study to confirm this. Okay, that's how all of this will conclude. So we will keep squeezing that data, torturing that data to get the answer that we are looking for. But please remember that that answer is not robust. And that's where this can fill in. This can fill in the gap. By no means am I trying to say that we should stop doing randomized controlled trials and keep doing only real world data generation. I'm just trying to tell you how we can complement or fill in the gaps that for the questions that we are asking, which are not properly and adequately, robustly answered in a randomized controlled trial. This is the definition of what real world data is. When you synthesize that data and you come out with some conclusions, that's called real world evidence. So it's a small difference between the two. One is just collecting data from multiple sources. We don't have time today to go into what these sources are. It can be as simple as your own records to big registries that today exist, public registries that are there, tumor registries that are there. You could get data from all of these, and then depending upon what question you're trying to answer, your source of data should be different. These data should be curated, they have to be robust, and so on and so forth. All that goes without saying, and there are ways and means of doing that, but you can get useful evidence from results like that. What are we seeing? This is the number of PubMed citations with somewhere in their title saying real world evidence. And you see that over time, this number is progressively going up. And that last bar is something that I have created. That's not data that's already there. But if you just project it in that direction, again, something rare. So you will probably end up somewhere there. So we're going to keep looking at this, hearing about this, and trying to implement this in our practice more and more often. Why is it that we need this? Because randomized controlled trials are not easy to run. They are resource intensive. We spoke about that in the last talk. Highly protocolized. They do not represent routine care, and that is not what happens in the real world population. It's very hard to assess long-term events. You've done this treatment today. What happened to that patient 10 years later? That's not something your randomized trial will tell you, because they will say our follow-up stopped at 3 years, our follow-up stopped at 5 years. What happened at 8 years? Is there a long-term side effect of the treatment that you have done today? We just don't know in a randomized trial. And in today's context, in this conference, we're talking about rare diseases, and Dr. Gupta beautifully told you about why it is very difficult to enroll patients and not get robust answers to that very relevant questions that you're asking for, especially in a rare situation. What are the problems with these real-world observational studies? There's a higher risk of bias and confounding factors, that goes without saying, and there are varying levels of data availability itself. So an RCT looks at, can the drug work? But real world explores the question as to whether this works or not, and that's very important. So it's like asking whether this is important or that is important. For me, both are important, because if the one on the left was not there, then the right would not be there too, and they have to complement each other so that you get the best out of whatever you're doing. So it's important that both this data are there. How can we use real world evidence to complement? So the question that we asked to begin with, how does this treatment work out of the clinical trial? What additional observed adverse event? All these patients that we see in the clinic come with the baggage. They've got so many other comorbidities, additional drugs that they're taking. What is the interaction between the intervention that you're doing versus some of those that are already going on in that particular patient? How is dosing adjusted in practice? Whenever somebody talks about PARP inhibitors, and we ask in a panel discussion, what is the dose that you start with? Nobody will say, I will say I'm starting with the full dose. Everybody will say, I start with 3 tablets, I start with 200, I start with 400, I look at that patient, how big, how small, all this will come. In a randomized controlled trial, you won't get that. Everybody starts full dose, 600 milligram, and then dose adjusted. But in reality, majority of us will eyeball, look at what's happened to that patient during the course of chemotherapy, nutrition, this, that, and then you will start with 3 tablets, come back in 1 week to see me, all this will happen, right? So doses and what happened, how long did they continue this treatment that you started? Does this treatment offer improved value, right? Value is a word with a lot of ramifications in terms of, overall survival, progression-free survival, cost, benefit, quality, so many things that the word value can actually stand for. So many of these things can be found out in real world evidence, which you probably don't have at the end of a randomized controlled trial. Now, we did speak about bias. So there are so many kinds of bias that can occur in real world data and the real world evidence that you are generating for various reasons, confounding. Missing data is very common, misclassification, selection, reporting. So there are so many problems. We do understand and we do acknowledge the presence of all of these problems, but they are not unsurmountable. There are ways and means of, doing certain adjustments to these data so that we are able to get over all of this to a certain extent. By no means can you get data as robust as what you get in the randomized controlled trial. But at the same time, you can get data of decent quality in a well-designed, conducted, randomized real-world evidence. I'm talking about a randomized real-world evidence. Why is it so? You can do randomized studies even in real world. You can do interventional studies even in the real world. For example, this set, who believe in a particular intervention for a particular disease will continue to do that. This group which believes in a particular intervention will do that. So automatically, in some way, they're getting randomized. Okay, we're not doing that block randomization or, picking up computer and all those stories. You keep doing what you're doing. You keep doing what you're doing. We'll meet again after 1 year and then put all of this data together. In some way, it's getting randomized. So it is possible to do that. There are certain statistical methods that can also be used in order to match patients, propensity score matching, doing some weighted analysis. All of these can be done in order to make sure that the data is better than just what you collected. And then this can answer some of the questions that you're looking for. Now, the other important thing is that even from a regulatory standpoint, this is something that's being accepted today. These are some drugs that were approved by the FDA only based on real-world evidence. Okay? Drugs are today being approved based on real-world evidence. So you don't need a 5,000 patient randomized controlled trial in order to get an approval. There are some drugs today that we get approval based on a phase 1/phase 2 study. You don't get into a phase 3 study at all. Okay, so this is going to keep happening more and more frequently. When you're going into this personalized medicine story, people are talking about N of 1 study. You know what is N of 1 study? You've got one patient, you did that intervention in the one patient, it worked. And so that's what you should be doing in the next patient also. So you had a molecular abnormality for which you have a targeted therapy. That molecular abnormality happens in 0.5% of patients in a disease that is extremely rare. How do you use that drug? Will it ever reach the clinic at all? It should. It will be of benefit to some patient. But how do you really know whether that drug is going to be useful? It's by generating good quality real world evidence that you will get some data regarding usage of interventions that are not very commonly used in uncommon diseases. If you thought this is not possible, it is very much possible. Dr. Ramesh Nimagada is sitting here. He is very passionate about this. Now we've got an OncoCollect group. We've done a lot of data on lymphoma. There's a big group that is sitting now and collecting data on breast cancer. He's got data on more than 1 lakh patients, demographic data, all in his system, right? So it is very much possible. Dr. Sudeep has helped write some papers, from the data that was collected earlier. So it's now published. So we've got 3 or 4 publications in lymphoma, some in cervical cancer, some in breast cancer. So getting together people from the country and putting your data into one system and then analyzing it can give you a lot of answers to very relevant questions that we are asking, which we can never ever get from randomized data that we are reading from Western studies. So it is very much possible. If you thought it's impossible, no. If I can erase that opinion from your mind, that's good enough. It is very much possible. The rare tumor registry that's being started is an effort in that direction. It's very important that all of us put those rare situations into that registry. And I'm sure in a couple of years or 3 years, all our strengths to get together will really matter to give us some very, very relevant answers. That's my last slide. I think real world evidence and data is all about patient-centered care. A lot of time I feel randomized controlled trial is not patient-centric, it is intervention-centric. So real world data, real world evidence, real world practice is patient-centered, right? A randomized controlled trial looks at efficacy. Real world evidence looks at effectiveness. And in a country like ours, and for any other geography, it's very, very important to also look at cost effectiveness, because that is very geography specific and you cannot generalize. So real world evidence is complementary to randomized controlled trials. And ladies and gentlemen, you cannot run away from this. It will increasingly impact the decisions that we will make in clinical practice today and for many, many more years to come. Thank you so much.